from the Psych Hub Podcast Network.
Hi, I'm Marjorie Morrison.
And this is Patrick Kennedy.
And you are listening to the Psych Hub Podcast, The Future of Mental Health. This is the first time we've ever done one live. I've never told anyone this. This is like a little secret here. But Patrick and I do a lot of texting while we're doing these recordings. And so I'll say like, okay, you get this question, you get that one. We're up here with no notes, and we always have notes of our questions. So poor Dr. Rhee, who prepped all these questions, he's, gonna be thrown out a little bit just of like impromptu because we've never done this live before. We are really so incredibly lucky to have you. Dr. Rhee is the Chief Medical Officer at Aetna. And maybe what we'll do is as we talk, we can have him talk about his incredible career that he's had to date. He spent a considerable amount of time at IBM. And then before that, he was at HRSA. And so really a public servant, and now has this opportunity of bringing that work into the corporate sector. So this will be our first live podcast, in-person podcast interview. And by the way, the impetus of this is our podcast is called The Future of Mental Health. So when the conference reached out, I was like, wait, I have an idea. I saw Senator Frist do this live podcast. We should do one. And then of course I lured Patrick into coming in, and we reached out to Dr. Rhee. So welcome to the show.
Thank you for having me. Thank you.
Maybe if it's okay, just you can start and just share a little bit about your past and what brought you to this place now.
So I like to reflect. I'm a primary care physician, so I was trained in internal medicine and pediatrics. So I practiced in underserved settings in DC and Baltimore as a National Health Service Corps scholar. For those of you who might not know that, that's like the Peace Corps in the US to work in underserved communities. So I had the privilege of doing that. And then I was interested in moving from one patient at a time to one population at a time, and had the opportunity to work at NIH under Dr. John Ruffin at the National Center for Minority Health and Health Disparities. He created a role called Director of Innovation, and we were looking at ways in which NIH could advance health equity or address health disparities. And then was fortunate to be able to be with Dr. Mary Wakefield as the chief medical officer of HRSA, which is the federal agency that serves a lot of underserved populations, including the community health centers and the National Health Service Corps that I was fortunate to benefit from. And then I was intrigued with how you could do public health in the private sector. And that's what led me to be the chief medical officer at IBM for a decade. And then now I feel like I'm going full circle because my first job right out of residency was at the corner of 14th and Irving in Columbia Heights, and the CVS was right across the street. And so now I'm at CVS Health and the chief medical officer of Aetna, and lead an amazing team of healthcare professionals who are committed to making sure people get the right care at the right time and address the values of mental health, prevention, and equity.
So Dr. Rhee, being a health officer at IBM kind of gave you an appreciation for how much data can really guide what decisions we make. I was really intrigued, in our former executive Blue Cross in Rhode Island, who's now head of Blue Cross Blue Shield Association, referred to your zip code has a bigger bearing on your health than your genetic code. And then you added the analogy to that where you were talking about practicing that one subway stop in Washington, D.C. in Maryland versus the next subway stop in the District of Columbia, the difference in life expectancy is 20 years between subway stops. So could you talk a little bit about your history at NIH around health justice, these inequities that frankly we've seen during COVID really exacerbate the disparities in health outcomes?
Yeah, and I'd reflect that going through residency and learning to be a primary care physician at Cedars-Sinai,
where I was born,
where you were born, taught me a lot about the pathophysiology of treating disease and medicine in some great settings. But once you get out there in the real world, like I was at the corner of 14th and Irving with the CVS across the street, next to a metro stop, Columbia Heights metro stop, I discovered that so much of what I did in that exam room played an important role, but it didn't often impact the health outcomes and the improvements that I was looking to address. And so one way I like to frame this is the 8,760 hours we have every year that we choose to spend with the people we love and different activities. But when you look at the data, talking about data, in general, the average person has 3 to 4 encounters a year through a claims-based system. So that means on average, as a primary care doc, I would see them for an hour a year. It's those 8,759 hours outside of that exam room that play such an important impact on your health. And so if you look at the science around this, McGinnis et al. Health Affairs, in general, 70 to 80% of health outcomes are connected to what happened outside of my exam room, which is why I got excited about thinking about the bigger picture, having worked in those community-based settings. Once again, having so much pride in the work we were doing on the front lines of healthcare delivery, but recognizing the system was much more complicated. And that data, for example, is an important source of influence and power. And if you follow the data, which often goes with also where the money goes, you can see what I call the 7 Ps of how data flows and how often the financing flows. Patient to provider, so I as a primary care doc and the patient. Then it goes often to a payer, right? Whether it's Medicaid, Medicare, or commercial plans. Then it goes to a purchaser. The employers have a huge amount of influence in our health system in the US, and I saw this at IBM as I looked at other health systems, how they viewed healthcare as a right. It was often centralized in certain entities, while in the US it's incredibly fragmented. Then you've got also the purchaser, the policymaker, so Medicare, Medicaid, they set policies, product manufacturers, and then pioneers like people in this room.
This is amazing.
So think about the data.
That was really cool.
Yeah.
Wait, so the pioneers are the ones that are kind of at either the beginning or the end of that circle, basically. They're like the advocates.
Like the people in this room are looking to the future of mental health care. Mm-hmm. And so part of the challenge you have to address is look at where the data flows, look at where the funding flows, and embrace the partnerships across all those diverse stakeholders. Mm-hmm. And if you do that and you seek to understand to be understood, and you look at the data you have, don't make perfect be the enemy of the good. Don't let the data we lack to be a barrier for the action we have to take. I think there's huge opportunities.
So, you know, as we work to try to enforce the Mental Health Parity and Addiction Equity Act, you know, we're looking at really just some basic metrics on comparability between medical, surgical, and mental health. But if you're looking at the future about what we need in this country, it's really more mental health than even the medical side, because we've squeezed down the medical spend as much as possible. We've never really embraced the opportunity to see the value of mental health if it's integrated along with social determinants of health. But we don't measure any of that. And it's interesting to me because I don't get it from the payers, any real leadership on the side of what's going to be beneficial to the consumers, those patients that we represent. Because if we're really about them, then listen, Patrick, who always goes after us on parity, we got something even better for you. That's better outcomes. And we can demonstrate better outcomes through value-based contracting, which actually enhance our ability to push more mental health than even the medical side. And the irony is parity might even be a detriment to a payer's ability to do more on the mental health side. But we rarely get kind of the leadership on the insurance side on that because, as you point out, they don't always have the fiduciary. The true fiduciary to one of your Ps is the purchasers. It's really the companies in this country who have the true fiduciary for their patients, because they're not only looking at the total cost of care, but they're looking at the impact on productivity disability, and so forth. Could you talk a little bit about how we need to focus on the purchasers in order to get the payers? Because frankly, Aetna is not just a payer, it's a purchaser for your own population.
Fortune 4 too. Fourth largest company in America, so big purchaser.
Yeah, and I want to emphasize part of what I'm very proud of is the fact that in many ways CVS Health has a lot of those P's connected,
right.
And we're looking across that ecosystem to create those partnerships within CVS Health, but beyond. But look, I learned a lot when I transitioned from the public sector to the private sector, and one of the roles that I had at IBM as the chief medical or chief health officer was the spend of our healthcare dollars. And so when you're a policymaker when you're a purchaser. So when we crafted policies for what we would cover, like primary care, we covered it early before the Affordable Care Act covered the preventive services and the primary care benefits. We covered it at little to no cost. So we knew that we were a policymaker. And so purchasers get data from payers and a broad range of stakeholders. I do like the phrase, you treasure what you measure, or you measure what you treasure. So if we treasure mental health, we need to measure it. And we need to ask ourselves, what are the measures that matter here to advance this transformation in health that values mental health as much as physical health?
Well, I think that your work at HRSA and then earlier than that on the equity side at NIH, if you could talk a little bit about what we need to do in terms of really getting data that allows us to, like we were talking about the zip code, other kind of data sets that could help us get a better sense of justice and injustice in terms of access to care, which is what we try to do with parity. But as I said, we've got a long ways to go to even improve that.
Yeah. So one of the things I'm proud of, Aetna was the first major health plan to collect race ethnicity data in around 2003. So this is a very important piece. If you want to address health justice or health inequities, one of the challenges we have in our society is health disparities based on race ethnicity. You can generally see in most metrics, including mental health metrics, that Black and Hispanics suffer significantly worse outcomes than whites and Native Americans as well in that group as whites and Asians. And Asians were a complicated group because we're so heterogeneous. So there's certain Asian groups that are suffering horrible disparities that get aggregated, and there's certain ones that aren't as much suffering disparities. So equity dashboards should be standard. So I actually wrote a piece on this in the Journal of Healthcare for the Poor and Underserved with some colleagues at Harvard and IBM, and we called the term tequity. How do we use technology to advance health equity? With 4 key components. Number 1, in healthcare and in technology and health tech, we need to make sure we represent the people we serve. So the US population is 51% women, 40% minorities. Look in the mirror, in your own team, in your own workforce, in your own employer group. Do you represent the people you serve? I'm proud of the fact that CVS does, in communities across this country, represent the people they serve. And I think this is why we played a very important role in the pandemic, where people came and got over 70 million vaccines and 50 million COVID tests, and we addressed health disparities through that. The second one is data trust. You need to collect the data. So this is very important. Everything in healthcare I learned, it's the same as it was in that patient-doctor relationship at the beginning. It's all about trust. And data represents how much you trust someone, sharing of that data, knowing how that data is used, and knowing that it's going to be used to help you or others. I think the concept of data privacy is important, but the concept of data philanthropy is important. You know, this idea that, I can donate my organs when I die, but how can data be used in a way of good to promote philanthropy and awareness about these disparities? The third component is equity dashboards. So at the turn of the century, Crossing the Quality Chasm, it identified 6 aims for healthcare quality: safe, timely, effective, efficient, and patient-centered. Equity was the Rodney Dangerfield, if those of you remember Rodney Dangerfield, of all the health equity measures, or all the health quality measures. And it's about time it gets addressed. As we saw during this pandemic, inequities are rampant through our society, and we have a responsibility to address them. So you can't apply until you know. So equity dashboards should be standard, and we should look at those disparities based on rurality, based on race, ethnicity, and based on other factors that we know based on the science, disparities exist.
Are privacy laws getting in the way?
Privacy there's nothing more important than trust. Privacy is core to anything and everything. So I would suggest that this partnership to assure privacy and protection, and that first stakeholder in the Ps, the patient, is the most important one. So I talked about this at IBM, and conceptually, I think the idea of, in the same way I go to the DMV and I donate my organs, and I'm an organ donor when I die, and I remember at HRSA we had the organ donation program. I think the concept of knowing how your data is used and being able to donate your data to key stakeholders is a concept that will hopefully inevitably evolve as we look at data privacy laws evolving as well.
Well, I like the idea of another analogy, and that's the advanced directives, what you think of when you become terminally ill or trying to plan for an major accidental problem. We need to have really push out advanced directives in the mental health space as a way where we can retain the dignity of the person who is self-directing their care. They're doing it while they're in a place of insight where they can really understand where their mental health is, so that if I'm coming out of rehab like I did a dozen times thinking I got this, but I forget within a short period of time that I have a chronic illness and that I don't have this, I've already laid and put in advanced directive that in those instances I want X, Y, and Z done, so that when I tell the loved ones around me, no, I got this, they say, no, Patrick, when you were in a more lucid moment, you said X, Y, and Z is what you wanted us to do. So no matter what you want, this is what you said you wanted. And it won't resolve the situation, but it'll empower family members to do more on behalf of their loved ones when those loved ones are in crisis and they can't do anything around it because the person's over 18 and so forth. So I love that idea of coming up with those analogies. The other big analogy I'd like you to comment on is with COVID and data. So I can look at my phone now and find out how many people in Atlantic County, New Jersey have COVID and what their comorbidities are. We did that within less than a year of COVID happening, yet the data around suicide and overdose is 2 years old. And as you know, it's messy data, which it just hobbles our ability as policymakers, unlike with COVID, to make the proper policy changes to meet whatever the need is today. So if the addiction crisis is being fueled by both certain types of fentanyl, analogs, and certain types of stimulants and meth, and where those are geographically and so forth, and where they are demographically. Boy, what a difference that could make, both at your experience at HRSA, to targeting the necessary resources right now that we're shoveling out the door in Washington, D.C. We're just shoveling cash out the door. How do we know whether it's going to the greatest need and going to have the best outcome? We don't, because we're not having data, help us determine where to spend the dollars on the federal side. So talk a little bit about how we need to have that public health response that we had for COVID for mental health.
Yeah, and I wrote a piece early in the pandemic. I'm just going to highlight it. I called it the 4 curves of COVID. So this recognition that, of course, there is going to be an extraordinary opportunity during this global pandemic to understand public health and the data of cases, hospitalizations, and deaths, vaccination rates, testing positivity. The whole public across the globe learned more about COVID. And when I was at IBM, we had the weather company, and we were debating and discussing what we were going to put as people checked the weather every day. And we put in some very solid scientific sources of data so that people could see as they check the weather, what are the case rates in their community. So I would suggest in the 4 curves, while we've been focused on infectious disease, there are other curves that have gotten worse during this pandemic that always were there. Chronic disease, mental illness, and inequities. So if you want to create a similar effort and movement around awareness and action as we did with this infectious disease, COVID, you do need, health is local. People need to see locally the data in their community and where they are and what they could do to act and improve on those numbers. And whether it's 988 or earlier detection, as a primary care clinician, I valued a significant percentage of the people I served had comorbidities, mental health, and they also had mental health issues like depression, anxiety disorder, and substance abuse. I was trained to do those things. Now, I didn't get as much training as I feel like I should have. So a lot of that I had to do ad hoc, which is a broader issue. But mental health should be core to what every healthcare professional is aware of and addresses. And part of making that core is, once again, going to the concept of measurement. If people see these measures are not meeting the needs of my community or what I would like for my family, then we need to show that, and we need to show what they need to do to act on it, like early detection, treatment, and even this concept of a mental health vaccine. I mean,
That's what I was gonna bring up, is that one of my favorite things that we did in COVID was we partnered with MHA and CVS, and we did a mental health vaccine card in, I don't know how many of the stores, but there was a QR code and people could get that information. And, for many of us in this room, and I've been in mental health for decades, right? This is an exciting time for us because now everyone's paying attention. And some of that comes from that work, right? Mm-hmm. Like that early on, yes, you're getting a vaccine. And remember, we handed out flyers at vaccine sites. We had some governors really pick it up. It was really cool.
Right.
We'll get right back to the conversation. But in the meantime, here's a heads up about PsychHub's newest podcast, Real Talk with Gen Z, sponsored by Aetna, a CVS Health company.
Hey there, and welcome to Real Talk with Gen Z, a new podcast miniseries from PsychHub, brought to you by Aetna, a CVS Health company. This is a conversation show. Members of Gen Z, like me, bring our unique perspective to discuss crucial mental health topics with the experts in mental health. We're coming out of a global pandemic, which impacted all of our mental health. But mental health still carries a stigma and can be scary to talk about. Listen as our Gen Z hosts discuss topics like loneliness and isolation, minority mental health, and LGBTQ+ mental health. Each episode is hosted by a different set of people with a personal connection to the subject matter. Real Talk with Gen Z will launch on June 30th. New episodes will launch every other Thursday. Subscribe here or wherever you get your podcasts.
Now, back to the show.
Yeah, and look, I'm going to use a parallel. I have to admit, I have a lot still to learn about mental health and the data elements and components. I'm in my career been very much a health equity champion, as well as a primary care champion, as well as a public health and health tech champion. And I think the opportunity we have, I'll give you an example. I published a piece with a number of colleagues at AAFP on a community health index. And we just use you got to use the data that's available. In my opinion, you got to start with what you know exists, like the ingredients in your kitchen. This is what we've got. So we came up, ironically, the term was PPE. So it was primary care, public health, and equity. And we looked with Glenn Mays. And,
you don't mind if I steal that?
No. It's been published. Actually, it's been. We need more PPE. It's been published, and in fact, there was a study done by the Primary Care Collaborative that showed in the quintiles that had the highest PPE had the lowest rates of COVID cases, hospitalizations, deaths, and higher vaccination rates. Mm-hmm. So now my challenge is to see and look at the data from a behavioral health perspective.
Right.
To me, there needs to be a behavioral health community health index using the data that's available that gives awareness at a local level where you are. And frankly, I knew at HRSA, we had HPSA. The reason why I was National Health Service Corps was because I was in a HPSA area, health professional shortage area. I was also medically underserved area. They have that data for behavioral health. National Health Service Corps, so that data exists to look at the workforce issues. And then you need something from a public health paradigm, which is what Glenn Mays helped us with, and then an equity paradigm. And we combined those three, valued them all a third, And that created the PPE index, which is the community health index. There needs to be a behavioral health index.
Well, we need to have a community health service corps and a mental health service corps. We basically need a recovery corps for not only enhancing, incentives for medical education to get more child and adolescent psychiatrists into the field, but also other professionals in the behavioral health field to get them incentivized, because workforce is the 800-pound gorilla for mental health. If we want to talk about the future of mental health care, we're not going to have care if you don't have providers. And I've been, and on several, Marjorie knows podcasts, I've been calling on AHIP over and over and over again to stand up with some leadership. You've got Ron Wyden, chairman of the Finance Committee, and Mike Crapo, who want to work together to get a bigger pipeline for more mental health providers. And do you think AHIP is in there and saying, here, how can we help? I mean, AHIP is going to get crushed by parity, because right now, there are not enough behavioral health providers to meet the requirements of the federal Mental Health Parity and Addiction Equity Act. So if you're an insurer, you want to get more providers in this space or you're going to get slammed. So why not get a partnership with the federal government during this reconciliation period? And it's not too late. That's the reason I'm mentioning it. For payers to say to Ron Wyden, we know that you've just gotten a huge study out in Oregon that showed a phantom network of children and behavioral health providers in Oregon, in his backyard, cannot get timely access. Forget about it across the country. We all know there's a challenge. But in his own backyard, as chairman of the Finance Committee, he wants to do this. Why not go to him and say, listen, Kennedy's over there beating the crap out of you on parity. Why not us go ahead of this game and provide a much broader system of measuring maintenance of effort by payers so they can show the investment that they're making in the future of mental health care, because they are helping to realign financial reimbursements to incentivize more people for going into this field, and they're making critical investments in the pediatric side that you mentioned by partnering with the American Academy of Pediatrics and other groups. It's just, I'm at the fault because I grew up seeing big deals get done. I saw my dad work with John McCain, Nancy Kassenbaum, Sam Brownback. They were polar opposites politically, but they recognized the value of coming together. And we're missing that right now in this moment of time where Tyler really said, where's the urgency and the leadership? And we're all here, but how do we get this to, and members of Congress want to be leaders, but they don't have necessarily the roadmap that the, CEO Huddle and others have put together. So what I'd ask is, what as a CMO do you think CMOs can do to show that if a payer really wants good value, they need to invest in this, getting the data? Because the data, like you said, will show, well, hey, maybe we want to spend more money on this mental health thing because the data shows that it actually buys us bigger returns for our dollar.
And just to piggyback on it, the amount of money saved on prevention is so huge, right? So there's really a total cost of care savings when you can invest in it, right? When we get people better mental health care earlier, everybody wins. But yet it's a hard argument to get people behind it.
Yeah, look, we're proud of Resources for Living. 30 million Americans have access to it. We're proud of the partnership and the work we've done together with PsychHub. And EAP programs have demonstrated generally like maybe an 8-to-1 ROI. So in some ways, there's a lot of studies that have shown an ROI related to mental health investments. And a lot of it has to do with the specificity. Are you doing into primary prevention, early detection and treatment? To your question about CMOs, like we have learned in this pandemic that every business is a health business. We have learned with Delta hired a chief health officer, Dr. Henry Ting. AMC Theaters hired a chief health officer. So in my mind, CMOs or CHOs, schmoes or chos, are your allies as it relates to this. Part of what inspired me to go from one person at a time to one population at a time is the ability to see this bigger ecosystem and the ability to see that one small change can have such a huge ripple effect for millions of Americans. Yeah. And so work with CMOs, to help look at the data, lead with the science, and identify the gaps that exist that we can work together to close. And I think every business at this moment, in the same way that they had to consider COVID and how it affected their business and their employees, everyone has to consider the impact of mental health and mental illness for their workforce and the people they serve.
So in Rhode Island, of course, we're really so small state in the country, we were able to get all the payers to put into a prevention fund at a per capita ratio of their market. So obviously the bigger payers paid more in than the smallers, but none of them were at a competitive disadvantage in terms of how much money they put in the prevention fund. Then as a community of payers, they could determine where they wanted to spend that money. But all of them were beneficiaries because the population was healthier by the time they hit the market, whether it's a Aetna or United or Blue Cross or what have you. It seems to me we need thought leadership from AHIP on those types of things because this is a win-win for payers. If they can get in early, which they're not financially incented to do, on the prevention side for kids' mental health, and we got a children's mental health crisis, why aren't they coming up with innovative ways saying, oh, hey, state, listen, we don't mind all being dinged a revenue enhancement or a tax, if you will, if it goes to this prevention fund, because we think the net will be that it'll reduce the future burden of illness of our future population coming into my insured population. And we're willing to partner with you, the state, to put in on that because you're going to save the justice system, the juvenile justice system, the special ed system, everything's going to change. And do the kind of braided funding models and others that have the really social impact, the whole social impact bonds concept. It's just shocking that we don't have more of that leadership from AHIP because they could help us get around this problem and help themselves at the same time.
And you see it in physical health all the time. I mean, prevention for diabetes and prevention for get your mammogram or you turn 50, get your colonoscopy. I mean, pushing prevention, but you really don't see it in mental health. And the other thing I want to add is your P's, going back to the patient. At Psych Hub, we call them consumers, right? Consumers of mental health. They're getting very savvy. I mean, on the Psych Hub YouTube channel, we're averaging about 1 million views a month. So there's just this huge appetite for people to learn more about mental health. And that's going to be pushing as well, right? Because they're going to they already are demanding more, which puts more pressure on the system. And when you think about prevention, getting people to lower levels of care that maybe don't need a psychiatrist or a psychologist, maybe a coach or a peer or a digital CBT app or something like that is the right thing for them. But I mean, obviously, we're in this business of education and we're launching in November our matching and our Connect. But with that said, that investment really needs to be there to say, hey, and I hear you because the data is what has to lead it all. But it is shocking to think how behind mental health is.
Well, the nurse-family partnership, everyone would agree, is one of the gold standards of early intervention. And look at how tough it's been to get that. Any wide adoption. Collaborative care, we know, but we got to boost the collaborative care codes. We have a lot of the agenda items that we need to push out. We just need to do them, like to your point, Tyler. So I just want to say thank you for having gone into the Public Health Service Corps, for your work at HRSA, how apropos that you had those experiences and then went on to be technology and data at IBM, and now you're CMO of one of the largest insurers in the country. And I really am excited, given your background, how your insight to these issues can help us internally within the payer community move them further ahead of the ball, because they really have the resources. Think about the last couple of years of COVID. They haven't had to pay for all those elective surgeries and patient stays. Their profits have been highest that they've ever been. And they have been showing greater inclination to pay more for other high need categories of providers than mental health, which is troubling, which is the reason why we have to keep banging away on the parity stuff. But listen, we want to be out there as consumers supporting what the payers want, because it makes good sense for us as consumers to lower our burden of illness, because it means better quality of life for us. But it also means good business sense for the payers, because it's a lower cost per subscriber if you get consumers that better chronic care and that better prevention, then will make the difference.
And I want to echo the thank you, because CVS Health and under Kyu's leadership has really put your money where your mouth is. I know on behalf of Psych Hub, under Kyu, we've trained so many pharmacists on our mental health ally. We have all of the hundreds of thousands of behavioral health providers on our platform, training them in evidence-based practice. You've made a commitment at the CVS Health hubs. We've really done great work together, and that's because you're, the whole ecosystem and the true ethos there of the company is amazing.
Yeah, and I want to thank both of you as leaders in this important work, and all of you out there, virtually and in person, that this requires partnership. It requires collaboration. It requires trust, which often means we have to have, a tough dialogue of where we are versus where we want to be. So I just want to thank you. With one, thought, I think there's such an opportunity in this moment. Brené Brown talks about vulnerability and the importance of vulnerability. And this pandemic has exposed us in many ways, and where our system needs to be in mental health care or mental health. And so I'm a big believer that as we evolve from evidence-based medicine, we need to move towards values-based care. Mm-hmm. And what are those values we have? And the people in this room have values of prevention, resiliency, mental health, and equity, and community. And so how are we going to make sure the data, the analytics, the workforce, and the commitments that the different Ps have deliver on those values so that we all are healthier? So thank you for having me.
Pleasure. Thank you.
Thank you.
As always, thank you for listening to our podcast.
If you enjoyed the show, drop us a review.
If you haven't already, subscribe to our podcast for the latest episodes.
For the latest insights, check us out at psychhub.com.